We tend to focus on the big ticket diabetes complications, the heart and kidney stuff.
Right.
But something that can seem, well, almost like a minor inconvenience on the surface is actually a massive threat for people with diabetes.
Yeah. Diabetic foot ulcers.
Exactly. DFUs.
Absolutely. What might start as, I don't know, a seemingly innocent blister or maybe just a bit of thickened skin, it can very rapidly turn into a serious health crisis.
And here's the statistic that really, really hits home for me. Somewhere between 10% and get this, 50% of diabetic foot ulcers lead to amputation.
Wow.
Think about that for a second.
It's a stark reminder, isn't it, that these seemingly localized problems can have just devastating, life-altering consequences if they're not properly understood and managed.
So in this deep dive, we're going to be dissecting the complexities of why these foot issues arise in people with diabetes.
Okay.
Our primary source for this exploration is the really comprehensive information found within Rutherford's Vascular Surgery and Endovascular Therapy.
A great resource.
Definitely. Consider this our shortcut to grasping the origins of these ulcers, the sort of domino effect they trigger in the body, and most importantly, the critical strategies for their management and prevention.
Right, the whole picture.
Our mission today is really a thorough understanding of diabetic foot abnormalities. Okay, let's get into this, starting with a really fundamental piece of the puzzle. Peripheral neuropathy.
Ah, yes, peripheral neuropathy. Nerve damage, basically, affecting areas outside the brain and spinal cord. It's indeed a central factor in developing these ulcers and the infections that often follow.
And it's not just one simple type of nerve issue, is it? It feels more like a perfect storm of different kinds of damage.
That's a good way to put it.
Caused by that prolonged high blood sugar and those small blood vessel problems we often talk about with diabetes.
Precisely. These factors lead to the degeneration of nerve fibers, resulting in what we classify as sensory, autonomic, and motor neuropathy, specifically affecting the lower limbs. And as you pointed out, each of these plays a really significant and often destructive role in ulcer formation, infection, and ultimately that risk of amputation.
So let's unpack those different types. We've got small fiber and large fiber neuropathy. What's the key difference there, and how do they typically show up?
Well, small fiber neuropathy often manifests with quite noticeable symptoms for the individual. Things like burning sensations, tingling, even sharp shooting pains that can feel electric.
Ouch.
Yeah. Interestingly, the clinical assessment for this type often involves checking if the patient can perceive temperature differences, something maybe not always done routinely.
Huh. Okay. And large fiber?
Large fiber, on the other hand, tends to present with maybe more subtle symptoms like numbness, that pins and needles feeling, sometimes a persistent sensation of coldness in the feet, even if they feel warm to the touch.
Right.
This type is more readily assessed in a clinic using tools like a 128 hertz tuning fork for vibration sense, a 10-gram monofilament for pressure sensation, and checking the Achilles reflexes.
And it's the severe large fiber sensory neuropathy that leads to this really critical and frankly kind of scary sounding concept. Loss of protective sensation, or LOPS.
Yes, LOPS. It's highly significant.
What exactly does that mean?
It essentially means the patient has lost the normal feeling in their feet that would typically warn them about an injury. Pain, pressure, temperature. It often starts gradually in the toes and can creep up the foot and leg.
That makes complete sense. If you can't feel something's wrong, you won't react.
Yeah.
The source material gives this really powerful example with attack. Can you walk us through that?
Certainly. Imagine someone with normal sensations stepping on a sharp tack.
Yep.
They'd instantly feel intense pain, pull their foot away instinctively, right? Prevents further damage.
Right.
But someone with LOPS, they might not even register the penetration. They could just keep walking, totally unaware there's a sharp object in their foot.
Oh, wow.
Pushing it deeper, introducing dirt, bacteria, foreign material, potentially leading to deep infections, tissue death.
And because they don't feel it.
Exactly. What's really concerning is this lack of awareness often leads to a big delay before they seek medical help. The absence of pain becomes the biggest danger, really. It masks significant damage until it's severe.
Which highlights why checking your feet daily is so crucial if you have diabetes, even if nothing hurts.
Absolutely. Proactive checks are key, and that delay can have really serious consequences down the line, can't it?
Oh, absolutely. The data indicates that individuals with diabetes and neuropathy are 5 times more likely to need multiple surgeries.
5 times.
and a staggering 46 times more likely to undergo an amputation as a direct result of an infected puncture wound compared to those without these issues.
46 times. That
Yeah.
just underscores the absolutely vital role of that protective sensation. It's incredible.
Beyond just the not being able to feel,
Hmm.
we also have autonomic neuropathy. How does that contribute to this cascade of problems in the diabetic foot?
Right. The autonomic system controls the involuntary stuff. In the foot, this disruption means problems with blood flow regulation and sweating. Specifically, you get an increased sympathetic tone, which can lead to abnormal shunting of blood between the small arteries and veins.
Shunting, so blood bypasses the capillary.
Exactly. Which can compromise oxygen and nutrient delivery to the tissues, potentially leading to small vessel ischemia.
Not good.
Not good at all. And autonomic neuropathy also affects the sweat glands, often causing anhidrosis or lack of sweating.
So dry skin?
Extremely dry skin, xerosis, it loses its natural moisture and elasticity, becomes prone to cracks, fissures, perfect entry points for infection. Plus, it can contribute to chronic edema or swelling, putting more pressure on already fragile tissues, increasing the risk of injury, leading to skin breakdown.
It really does sound like a vicious cycle where one problem just makes another one worse.
It is. It's like the body's natural protective mechanisms are being undermined from multiple angles.
Now, when it comes to treating the large fiber neuropathy itself, the actual nerve damage, the sources suggest there aren't really any established treatments to reverse it.
That's correct. Currently, there's no specific proven treatment that can regenerate or fully reverse large fiber neuropathy. It's frustrating. However, the often bothersome symptoms associated with small fiber neuropathy, like that burning and tingling pain,
Yeah.
those are frequently managed off-label using a variety of oral medications.
I'm talking about things like certain antidepressants, antiarrhythmics,
Yeah.
maybe even anticonvulsants like gabapentin. Yeah.
Exactly, those are common. And in addition, some vitamin supplements containing specific forms of folate and B12, as well as topical meds like clonidine and capsaicin, have shown some effectiveness for some people.
Okay.
And it's important to mention the two FDA-approved drugs specifically for painful diabetic neuropathy, pregabalin and duloxetine.
Right. Lyrica and Cymbalta.
Those have demonstrated benefits in reducing that neuropathic pain and also improving sleep quality for certain patients, which is a big deal.
Definitely. Okay, so that's sensory and autonomic. What about motor neuropathy?
Yeah,
How does
right.
that impact the actual structure and function of the foot?
Motor neuropathy affects the muscles in the foot. It leads to atrophy, weakening, and wasting, and an imbalance between opposing muscle groups.
Especially those small intrinsic muscles inside the foot.
Precisely. Those little muscles are key for fine motor control, maintaining the arch, stabilizing the toes.
Okay.
When they weaken, the stronger extrinsic muscles in the leg, which also pull on the foot and toes, can overpower them.
An imbalance.
Exactly.
Right.
In the toes, for example, this imbalance between the long flexors and extensors and those weakened intrinsic muscles can cause the toes to contract, become deformed over time.
Leading to structural issues like hammertoe.
Hammertoe, or the toe buckles, and hallux abducta valgus, which most people know as a bunion.
Right.
And these deformities are really significant in terms of increasing ulcer risk because they create new abnormal pressure points on the foot.
And the source material mentions a really high percentage of ulcerations are linked to both neuropathy generally and these specific deformities.
Indeed. It's reported that a significant majority of ulcers are associated with neuropathy, and a large proportion of those are specifically related to these structural deformities.
Wow.
Think about how a hammer toe develops. As those intrinsic flexor muscles atrophy, the toes can't stabilize properly when you walk.
Okay.
This lets the long flexor muscles pull harder, causing the toe to buckle at the middle joint, and it can eventually even dislocate where the toe meets the foot.
The MTP joint.
Right. That now prominent bony knuckle on top of the toe and the tip of the toe can then rub against shoes. While the buckled position can also create increased pressure on the sole of the foot right under the metatarsal head. It's a cascade of biomechanical changes, all triggered by the nerve damage.
It's incredible how interconnected all these seemingly separate issues really are. It's not just one thing.
Not at all.
Now, the chapter also briefly touches on surgical decompression of certain nerves in the leg, like the peroneal and tibial nerves.
Yeah.
What's the rationale there?
Yeah, in select cases, ones that aren't too advanced, there's some thought that surgically relieving pressure on these nerves might help. Some studies, like those by Women and McCare-Van Morick,
Okay.
have shown some encouraging early outcomes, mainly in terms of pain reduction after the procedures. Wyman reported a significant percentage getting pain relief fairly quickly after posterior tibial nerve decompression.
Uh-huh.
And McCare-Van Morick's trial also showed notable pain improvement in the surgical leg, lasting up to a year.
But it sounds like this isn't quite a standard treatment yet.
That's correct. The source material points out there's still limited prospective research, and we lack comprehensive long-term data on whether these decompressions really prevent ulcers or improve foot health long-term.
So, promising, maybe, but needs more study.
Definitely, more rigorous investigation is needed. Okay, so we've explored the impact of nerve damage. Now let's shift focus to another absolutely crucial element, peripheral arterial disease, or PAD.
Right. Blood flow.
How does insufficient blood flow factor into the development and, maybe more importantly, the healing of these ulcers?
Perfusion, getting oxygenated blood to the foot, is absolutely paramount. The chapter really emphasizes its critical role. It determines if an ulcer heals, what level of amputation might be needed if it doesn't, and ultimately limb salvage success.
Precisely. Without adequate blood supply, the tissues just don't get the oxygen and nutrients needed for repair.
Yeah.
And their ability to fight off infection is also significantly impaired. It's a double whammy.
Now, accurately measuring that blood flow in the diabetic foot, that presents its own challenges, doesn't it? Traditional arterial Dopplers aren't always reliable.
That's often due to a condition called Monckeberg sclerosis. It's calcification in the middle layer of the artery walls.
So the arteries get hard.
Exactly. They become rigid, incompressible, which means traditional Doppler pressure measurements, like the ABI, can give falsely elevated or just unreliable readings.
Okay, so ABI might look normal even when there's poor flow?
It can happen. Toe pressures and waveform analysis can sometimes give better info about the microcirculation, but as the chapter notes, many patients with these issues have already had previous toe amputations,
Oh, right.
which makes getting toe pressures technically difficult or even impossible. So yeah, the hardened arteries make standard methods tricky. Clinicians often need more specialized techniques.
And there's been a fair amount of excitement surrounding newer imaging tech, like hyperspectral imaging, HSI, and SPY fluorescence imaging. What's the current thinking on their usefulness here?
Yeah, there was initial enthusiasm. Early studies suggested HSI, which looks at tissue oxygenation, could potentially predict which ulcers might heal. Studies by Nuvong and Kaudiar reported promising sensitivity and specificity.
Okay.
But subsequent research, like Jeffcoat's work, has given more conflicting results. Some findings even showed a negative correlation with healing at certain points.
Not so clear-cut then. What about SPY?
SPY fluorescence imaging uses that indocyanine green dye to visualize blood flow in real time, usually during or after a vascular procedure. It's valuable for checking the immediate success of revascularization,
Okay.
but it doesn't give quantitative measurements. You can't put a number on the flow easily to compare patients or track changes numerically over time.
So, interesting insights, maybe, but not quite ready for prime time and predicting healing or guiding amputation levels.
That seems to be the consensus. It's still an evolving area. Robust evidence isn't quite there yet.
Still very much a work in progress, it sounds like. The chapter also introduces the concept of angiosomes. Can you explain what those are and why they might be relevant?
Sure. Angiosomes are basically defined anatomical territories in the foot and lower leg. Each territory is supplied by a specific source artery, the posterior tibial, peroneal, or anterior tibial.
Okay, like zones of blood supply.
Exactly. The underlying idea is that there might be a direct correlation between where an ulcer is located and which of these source arteries has compromised flow.
Ah, I see.
Some studies suggest that if an ulcer is in the angiosome territory of a blocked artery, then specifically reopening that particular artery, direct revascularization, might be especially good for wound healing.
Targeting the flow directly to the wound zone.
That's the idea. Targeting the blood flow to the area that needs it most.
But it's not quite as simple as one artery per zone, is it? I thought the foot had good collateral circulation.
It does, exactly. The foot has a rich network of connections between these main arteries. Redundancy.
Okay.
This means even if one vessel is blocked, the others might compensate and provide enough flow for healing. We sometimes see this with successful indirect revascularization, where opening an artery supplying a different angiosome still helps.
Right.
However, despite that collateral flow, the current consensus among vascular specialists generally leans towards attempting angiosome-targeted direct revascularization whenever it's technically feasible.
Why?
It's thought to have the potential to enhance wound healing rates, maybe particularly in certain spots on the foot.
That makes sense. Go directly to the source of the problem if you can. Now, when a diabetic foot ulcer is also infected, how does that complicate the timing of revascularization versus surgery?
Infection changes the game. When there's significant infection, the immediate priority often shifts. You need to surgically remove the infected and dead tissue first, as thoroughly as possible.
Before trying to improve blood flow.
Yes, absolutely crucial. You don't want to introduce infection into any grafts or stents you might place during revascularization.
Makes sense. What about ulcers that are mainly ischemic, mostly due to poor blood flow, without obvious major infection?
For those, it's generally advised to avoid aggressive debridement or surgical cleaning until after blood flow has been improved. Unless, of course, there's a strong clinical suspicion of a deep infection needing immediate source control.
Okay. And what about areas of necrotic tissue or dry gangrene? How are those handled regarding blood flow?
Well, necrotic or gangrenous tissue will ultimately need removal, usually via amputation. But it's important to do that amputation at a level where the remaining tissue has adequate blood supply to heal.
Right.
So in the case of dry necrosis, where there isn't significant active infection, it's generally best to delay major debridement or amputation until after revascularization, if that's an option.
But you mentioned earlier, it can be hard to tell if there's infection in these patients.
Exactly, the impaired host problem. Recognizing subtle signs of infection can be really challenging because those classic inflammatory responses might be blunted or absent. Clinical judgment is paramount here.
It sounds like a very delicate balancing act.
Yeah,
Address infection, ensure blood supply for healing.
it really is.
Finally, in this section, the chapter mentions classification systems like Wagner and the University of Texas system for DFUs. What's their purpose?
These are standardized ways to categorize the severity of the ulcers. The older Wagner system mainly grades based on depth and the presence of gangrene. The University of Texas system builds on that. It considers depth, but also incorporates the presence and severity of infection and ischemia, the lack of blood flow.
So it's more comprehensive.
Yes, it gives a broader picture. As mentioned in the book's Table 117.1, there's some overlap between them.
And why use these systems?
They're valuable tools for clinicians. They provide a common language to talk about the ulcer's severity, they help guide treatment decisions based on the stage, and they can give some indication of the likely prognosis or outcome. The UT system, by including ischemia, really captures more factors impacting healing.
Got it. Okay, so we've covered nerves and blood vessels. Critical stuff. Now, let's turn our attention to the biomechanics of the diabetic foot. It sounds like the actual structure and the way the foot works are profoundly affected.
Absolutely. As the chapter describes it, the foot is incredibly intricate. Bones, joints, tendons, ligaments, all working together.
A complex machine.
Totally. And diabetes really disrupts this delicate balance. It has a widespread and often devastating impact on the foot's normal biomechanical function.
And it's not just the initial problem. Even an amputation can cause more biomechanical changes.
That's a really crucial point. Amputation, even of what seems like a minor part, fundamentally alters weight distribution and movement patterns during walking.
Okay.
This can set off a chain reaction, adaptive, often worsening structural deformities, tendon and muscle imbalances, limited joint motion. It becomes a cycle that unfortunately can significantly raise the risk of recurrent ulcers, infections, and maybe more amputations.
Wow. So what are some specific structural changes that commonly happen in the diabetic foot because of all this?
One key thing is a progressive stiffening of the soft tissues, tendons, ligaments, the joint capsules.
They lose flexibility.
Exactly. Loss of natural flexibility and elasticity. This leads to restricted range of motion across various joints in the foot and ankle.
And that limited motion causes problems.
It can contribute to joint subluxation, where bones in a joint partially slip out of alignment, and in severe cases, even complete dislocation.
And what causes this stiffening and these deformities in the first place?
A couple of primary factors. First, that motor neuropathy we talked about leads to atrophy, wasting of the small intrinsic muscles within the foot.
Okay, the fine-tuning muscles.
Right. At the same time, chronic high blood sugar leads to the buildup of advanced glycation end products, AGs.
AGs.
Yeah. These AGs accumulate in the collagen fibers of tendons, making them shorter, thicker, and less elastic.
So weak muscles and stiff tendons.
Exactly. That combination, intrinsic muscle weakness plus stiff, short tendons, creates an imbalance of forces across the joints. That ultimately leads to those characteristic deformities like hammertoes.
The bent toes. hammertoes.
And equinus deformity. That's a significant limitation in pulling the foot upwards at the ankle, the dorsiflexion.
Okay, limited ankle bend.
Yeah.
And how do these limitations in joint mobility then directly lead to something like a plantar forefoot ulcer, an ulcer on the ball of the foot?
Well, when joint mobility is restricted, especially that equinus deformity, people unconsciously compensate when they walk. To make up for not being able to bend the foot up properly at the ankle during push-off, they might excessively abduct, turn the foot outwards, and pronate, roll it inwards.
Ah, an altered gait?
Yes. And this altered pattern significantly increases pressure and shear forces right on the sole of the forefoot, under the metatarsal heads.
The ball of the foot.
Exactly. That area becomes highly susceptible to ulceration from the repetitive stress and pressure. The body's trying to adapt, but it inadvertently creates these new high-pressure zones.
That makes perfect sense. The body adapts, but creates new problems. The chapter also mentions callus patterns.
Yes, the location and pattern of callus buildup on the soles can be a very reliable visual clue. It shows areas of abnormally high pressure and shear forces during weight-bearing.
Which are the danger zones?
Precisely the same forces that often precede and directly contribute to ulcer development. Similarly, watching how someone walks.
Changes in gait.
Yeah, things like shorter, shuffling steps, an antalgic gait trying to avoid pain, widening their stance for stability, or just general unsteadiness. These can all be important clinical signs signaling underlying biomechanical issues and areas of increased risk.
When a clinician is examining the foot, the reducibility of a joint malalignment seems important.
Yeah.
What does that mean, reducible?
Reducibility refers to how much a joint that's out of alignment can be manually put back into its correct position during an exam.
Okay.
A deformity is reducible if it can be fully corrected with gentle manipulation.
Mm.
Semi-reducible means it can be partially realigned, but not fully. And non-reducible means it's fixed, stuck, can't be manually corrected.
And why does that matter?
Assessing reducibility is important because these deformities tend to progress over time, from flexible and reducible to more rigid and non-reducible. As that happens, the treatment options often become more limited, and surgery might become more complex or less effective.
Okay, so understanding these biomechanical issues is clearly fundamental. Now, what practical steps can be taken, especially for preventing and healing ulcers? The chapter really stresses offloading.
Offloading is absolutely a cornerstone. Simply put, it means using various methods and devices to protect the foot and significantly reduce pressure and shear forces on the ulcerated area.
Taking the weight off.
Exactly. If excessive pressure is linked to those structural deformities or limited joint mobility, surgery might be considered to fix the anatomy. But the initial and often ongoing focus of conservative offloading is
Yes.
redistributing weight away from the ulcer, spreading it over a broader area, modifying how the person walks to minimize stress, and significantly reducing weight bearing on that foot during healing.
And what are some common, effective, conservative offloading techniques?
They range from simple things like protective padding around the ulcer, to custom molded or prefabricated orthotics and braces, to over-the-counter fracture boots, and then the gold standard for certain plantar ulcers.
Yeah.
Total contact casts, or TCCs.
The TCC seems really highly regarded in the chapter, especially for ulcers on the sole. What makes it so effective?
Yeah, a lot of research consistently shows TCCs are the most effective offloading for plantar ulcers. Studies report impressive healing rates, often 70% and 90%, with an average healing time around 42 days.
Why so good?
The total contact of the cast with the whole lower leg and foot helps distribute weight more evenly over a larger surface area. It dramatically reduces that concentrated pressure right on the ulcer.
Makes sense.
Unfortunately, as the chapter points out, TCCs are often underutilized, frequently due to lack of specific training for providers in applying and managing them, or lack of appropriate facilities.
What about those removable cast boots, cam walkers, and other specialized shoes? How do they compare?
Removable cast boots, cam walkers, are very commonly used, and while they do provide some offloading, studies show a much wider range of healing rates, maybe 22% up to 79%.
Big range.
Yeah. Healing sandals, therapeutic shoes, and insoles tend to have even lower success rates in studies, maybe 21% to 58% healing within 12 weeks.
Why are TCC so much better then?
One potential reason is compliance. Because the TCC can't be easily removed, the patient is forced to maintain offloading.
Forced compliance.
Right. With removable devices like cam walkers or shoes, patients might, well, not wear them as consistently as prescribed, especially at home or overnight.
That makes perfect sense. Hard for an ulcer to heal if the pressure keeps coming back. Now, for ulcers that don't respond to conservative measures or keep coming back, the chapter talks about surgical correction. What's the main goal there?
The primary goal of surgery here is to address the underlying structural deformities causing that abnormal pressure and ultimately create a more balanced or rectus foot.
Okay.
Soft tissue procedures like tendon lengthening are usually for deformities that are still reducible or semi-reducible.
Like lengthening the Achilles tendon.
Exactly. That's
Okay.
a common one. It can be tight in people with diabetes due to those AGE changes we discussed. Lengthening it has been shown to significantly reduce peak plantar pressures in the forefoot, maybe by as much as 27%.
Oh.
Studies report really high DFU healing rates after that kind of procedure, like 93% to 100% within about 12 weeks, if it addresses the root biomechanical issue.
And does it help prevent recurrence?
Yes. What's particularly encouraging is the reulceration rate is often significantly lower compared to just using a TCC alone,
Yeah.
because the surgery aims to correct the underlying cause of the pressure.
That's key. And for specific toe contractures, like hammertoes.
There are procedures like digital flexor tendon releases.
Hmm.
Often less invasive, they can release the contracted tendons, reducing pressure on the top and tips of the toes, common ulcer spots with hammertoes.
Okay. What about non-reducible fixed deformities?
Then bony procedures become more necessary. Things like exostectomies, surgically removing bony bumps causing pressure,
Mm.
and various joint realignment procedures like resectional arthroplasty, where part of the bone in a joint is removed to improve alignment and reduce pressure.
Complex stuff.
Often, these bony procedures are combined with soft tissue balancing like tendon lengthening or even skeletal reconstruction like midfoot fusion to get the best long-term result.
Right.
And it's crucial to remember, even after successful surgery, ongoing offloading with therapeutic shoes, custom insoles, or bracing is still usually needed long-term to prevent recurrence.
So surgery isn't a magic bullet. You still need the aftercare.
Absolutely. The ultimate goal of all these interventions, conservative and surgical, is to optimize foot function while minimizing the risk of new or recurrent ulcers. Okay, having explored the causes and biomechanics, let's focus specifically on the DFU itself and how it's managed directly.
The chapter makes it clear there's a wide array of treatment strategies, each targeting specific aspects of the problem.
That's absolutely right. You'll see treatments aimed at managing drainage, reducing swelling, getting rid of infection and biofilm, or directly stimulating healing processes.
So many options.
Yeah, the sheer number and diversity really underscore that there isn't a single one-size-fits-all treatment algorithm for DFUs. The approach often reflects the ulcer's characteristics, the patient's overall health, and the training and experience of the healthcare team.
But even with all these advanced therapies, there are fundamental wound care principles that need to be solid first.
Absolutely. The chapter emphasizes the foundations. First, ensure adequate blood flow. Then, provide optimal, consistent offloading. Effectively control infection and biofilm, and optimize the patient's overall metabolic and nutritional status to support healing from within.
Those have to be in place.
Yes. And remember, while antibiotics and dressings play a crucial supportive role optimizing the wound environment, they don't directly cause the ulcer to heal on their own. They create a better environment for the body's own healing to work.
The concept of converting a chronic non-healing ulcer into more of an acute wound sounds interesting. What does that involve?
Essentially, it involves regular, thorough debridement, removing all the non-viable, infected, or poorly perfused tissue from the wound bed.
Cleaning it out.
Right. This process helps stimulate the remaining healthy tissue and creates an environment more conducive to the body's natural healing cascade. Regular debridement also lets clinicians accurately assess the wound and plan for definitive closure, like skin grafts or flaps, once it's clean and has good blood supply.
And in some really challenging cases, chronic ulcers.
Yep.
Amputation is also considered a viable, sometimes necessary option.
Yes, particularly with severe uncontrolled infection or critical limb ischemia that can't be adequately fixed with revascularization.
Okay.
In those situations, amputation becomes a crucial intervention. It removes the diseased tissue, relieves pain, prevents infection spread, and ultimately aims to improve the patient's overall functional outcome and prevent potentially life-threatening complications.
And even then, the type of amputation matters.
Yes. For example, a well-planned transmetatarsal amputation, TMA, which preserves the weight-bearing arch, can often result in a very functional limb when combined with appropriate custom shoes and ongoing vigilant foot care. Now let's move on to discussing a really severe, often devastating complication, Charcot-neuroarthropathy.
Charcot-neuroarthropathy, CN, often just called Charcot foot. Sounds very serious. The chapter calls it a potential end-stage sequela.
It is indeed severe, with substantial clinical and economic impacts. Research shows CN development significantly increases healthcare costs and leads to longer hospital stays.
And how common is it?
Prevalence data varies, but estimates range somewhere between maybe 0.5% and 8% of individuals with diabetes eventually developing it.
And what's the fundamental cause? How does Charcot foot happen?
The prevailing theory centers on a combination of bone demineralization, weakening of the bone, coupled with that profound peripheral neuropathy.
Okay.
This loss of bone density leads to instability in the bones and joints of the foot and ankle. In someone with significant sensory neuropathy who keeps walking.
Because they can't feel it.
Right. This instability can result in fractures and dislocations, often triggered by what might seem like minor acute trauma or just the cumulative effect of repeated low-level stress. And critically, because of the neuropathy, these injuries might not be painful or even noticed initially.
Wow. The chapter briefly outlines 4 clinical stages of Charcot.
Cool.
Can you give us a quick overview?
Certainly, there's an initial acute or developmental stage. The foot gets noticeably warm, swollen, often red erythematous, but the pain might seem disproportionately mild given the damage.
Stage 0 or 1.
Stage 1 involves bone fragmentation, cartilage destruction, cyst formation, erosions visible on imaging. Stage 2, subacute, involves progressive joint subluxations, bones slipping out of alignment.
Okay.
Stage 3 is chronic or coalescence. The arch often collapses, creating that classic rocker bottom deformity. Fragmented bones start healing and fusing together. Coalescence begins.
And stage 4?
Stage 4 is reconstruction or consolidation. Bony fusion is largely complete, often locking the foot in a significantly deformed position.
And what are the key principles for managing Charcot, especially early on?
Early recognition is absolutely crucial, followed by immediate and complete non-weight-bearing immobilization of that limb.
Get off it completely.
Yes, to prevent further bone destruction and joint damage. This strict immobilization is usually needed for an extended period, often several months, until the acute inflammation subsides and the bones start stabilizing.
And then long term.
As it moves into the chronic consolidation phase, management often involves custom-molded braces and specialized therapeutic shoes to accommodate the deformity, provide support, and prevent new skin ulcers.
What about surgery?
Surgical reconstruction is sometimes considered for complex cases to try and realign the foot, but it's technically challenging and comes with relatively high rates of complications, even amputation. The textbook's Chapter 119 goes into much more detail on Charcot for those interested.
Good to know. Okay, so we've covered a lot. Nerves, blood vessels, biomechanics, Charcot. Now let's consider the patient themselves, what the chapter calls the impaired host. How does the overall health of someone with diabetes affect their response to foot problems?
Right, the impaired host. The chapter emphasizes that individuals with diabetes often have a blunted or impaired inflammatory response.
What does that mean practically for foot infection?
Practically, it means their body's natural defenses against injury and infection aren't as strong or effective as in someone without diabetes.
Okay.
This can unfortunately lead to much higher rates of hospitalization and a greater risk of severe complications from foot infections.
So they get sicker, faster.
Potentially.
Never
And
mind.
even with limb-threatening infections, those classic outward signs, major redness, localized heat, intense pain, significant swelling might be minimal or even completely absent.
Wow.
Even the systemic signs we look for in severe infection fever, high heart rate, rapid breathing, high white blood cell count, the SIRS criteria might be surprisingly normal.
Making it harder to diagnose early.
Much harder. This lack of typical inflammatory signs can make early diagnosis and timely intervention really challenging. The usual warning signs might just not be there.
So why is their immune response blunted like that?
The proposed mechanism is that chronic high blood sugar is associated with functional impairment of key white blood cells, especially neutrophils.
They're bacteria fighters.
Exactly. In diabetes, these neutrophils may show delayed movement to the infection site, impaired chemotaxis, reduced ability to engulf and destroy bacteria, poor phagocytosis, and impaired function of a key enzyme, myeloperoxidase, needed to kill microbes.
So the immune system is basically handicapped.
In a way, yes. This dysfunction allows bacteria to evade defenses and thrive, leading to chronic wounds and increased susceptibility to severe spreading infections.
What about ulcers that don't seem obviously infected? The chapter mentions they still have interesting characteristics.
Right. Even chronic DFUs without clear clinical signs of infection often have high levels of pro-inflammatory cytokines in the wound environment. And they harbor a complex community of microorganisms, bacteria, fungi, the wound microbiome. Interestingly, advanced imaging like electron microscopy shows biofilms.
Biofilms, those slimy layers bacteria make.
Exactly. Structured communities of microbes in a protective matrix. They're found in virtually 100% of chronic DFUs.
Wow.
But the precise role and impact of these biofilms on healing is still an area of active research and debate. Okay, so infection is clearly a major hurdle. Let's delve deeper into that critical aspect.
Infection is definitely highlighted as a major complication, a primary driver of hospitalizations and amputations. And the key point emphasized is that diagnosing infection relies heavily on clinical signs and symptoms, not just superficial swab cultures.
That's a really crucial distinction, especially since, as we said, diabetic patients might not show typical inflammation.
Right.
The most common entry point for infection is an existing ulcer or a puncture wound. It's relatively uncommon for foot infections to spread just through the bloodstream without a skin break. As infections progress, they can go deeper, forming abscesses, and eventually involving the bone osteomyelitis.
And what kind of bugs are usually involved in these diabetic foot infections, DFIs?
Most commonly bacterial, can be one type, monomicrobial, or more often a mix, polymicrobial. Staphylococcus and Streptococcus species are very common culprits.
The chapter mentions an updated IWGDF classification system for these infections. What's new there?
The updated International Working Group on the Diabetic Foot System has 6 categories now. Importantly, it provides a clearer separation between moderate and severe bone infections based on whether those systemic signs, SIRS criteria, are present.
Separating osteomyelitis severity better.
Yes. Historically, IDSA and IWGDF had slightly different approaches for soft tissue versus bone infections. This new distinction for osteo reflects the often different, more aggressive treatment needed for bone infections,
Right.
and also acknowledges the generally poorer clinical outcomes associated with osteomyelitis.
And those outcomes are significantly worse with osteo, aren't they?
Yes, unfortunately. Patients with osteomyelitis tend to need surgery more often, have more procedures overall, higher rates of subsequent amputation, need longer antibiotic courses, and sadly have higher recurrence rates even after treatment.
So how are these acute DFIs typically treated?
Initial management usually involves broad-spectrum IV antibiotics to cover the likely suspects, often followed by surgery.
To do what?
Decompress abscesses, remove all infected and dead tissue via debridement, and sometimes amputation if needed to control the infection.
Okay.
Once deep tissue and bone cultures are obtained during surgery, antibiotics can be tailored to target the specific organisms identified. It's not uncommon to need multiple trips to the OR until all non-viable infected tissue is gone. Then a plan for definitive closure can be made.
And what about that biofilm role again? Sounds controversial.
It is somewhat. We know biofilms, those structured communities in a protective matrix, are common in chronic wounds, on medical devices, etc. The bacteria inside biofilms have lower metabolic activity, making them inherently more resistant to traditional antibiotics compared to free-floating bacteria.
Harder to kill.
Much harder. While free-floating bacteria can detach and cause acute flares, the exact role of the biofilm itself in established infections, especially osteo and chronic wound healing, is still debated.
But because they resist antibiotics.
Physical disruption is key. Meticulous surgical debridement, maybe adjunctive methods like ultrasound-assisted debridement or topical antiseptics are often considered necessary to break down that protective barrier. Okay, now let's shift focus specifically to osteomyelitis in the diabetic foot context.
Osteomyelitis, bone infection. Sounds particularly serious and challenging. The chapter gives some pretty concerning figures on how common it is in DFUs.
It does. Osteo is found in a significant number of diabetic patients with foot ulcers, maybe up to 20% in outpatient settings.
And in hospitalized patients.
Alarmingly higher. Some studies reported in up to 67% of patients hospitalized for a DFI.
Wow, 2/3 in some cases. And how does the bone usually get infected?
In the vast majority of diabetic foot cases, it spreads directly from a nearby soft tissue ulcer, contiguous spread.
Okay.
In fact, a simple bedside test, the probe-to-bone test, where a sterile blunt probe easily reaches bone through the ulcer base, has a very strong positive correlation with underlying osteomyelitis.
So that simple test is a really valuable clue. What about other diagnostics?
Diagnosis usually combines clinical findings, X-rays showing bone destruction or fragmentation, and MRI findings. MRI is generally considered the best imaging for detecting osteo.
But the gold standard.
Still a bone biopsy. That allows for culturing bacteria directly from the bone and histological exam under a microscope to confirm infection.
Are there any blood tests or lab biomarkers helpful for diagnosing or monitoring osteo?
Yes, several studies show various lab markers are useful, both for initial diagnosis and for monitoring treatment response and detecting reinfection.
Like what?
For instance, an elevated ESR, erythrocyte sedimentation rate, above 60 millimeter R, and CRP, C-reactive protein, above 7.9 milli-GDL, are often cited as cutoffs to help differentiate osteo from just soft tissue infection.
Okay.
These inflammatory markers, along with others like procalcitonin, IL-6, IL-8, MCP-1, can also help track antibiotic effectiveness and detect early signs of recurrence after treatment.
And recurrence is a big problem.
Unfortunately, yes. Reinfection rates after treatment for DFIs, especially involving bone, are quite high. Over 30% for soft tissue infections and over 50% for bone infections experience reinfection within a year after hospital discharge.
50% recurrence for osteo within a year. That's huge.
Mm.
Are there specific biomarker levels that might predict who's at higher risk for this?
Yes, research has identified specific cutoff values for markers like ESR, CRP, procalcitonin, IL-6, IL-8, and MCP-1 that seem predictive of increased reinfection risk after treatment. Interestingly, the chapter highlights that ESR and CRP are relatively inexpensive and readily available, making them potentially useful for routine monthly monitoring after osteo treatment to hopefully catch recurrence early.
Okay, we've thoroughly examined the complications, which are significant. Now let's turn to what's arguably the most important aspect, prevention.
Absolutely.
Yeah.
The chapter strongly emphasizes there's a really significant opportunity here. We can fundamentally alter the natural history of these complications by proactively focusing on and implementing effective prevention.
It seems like such a logical and essential part of diabetes care.
It certainly does, though translating it into consistent practice and patient adherence can be challenging. The chapter notes that many patients seen by vascular surgeons already have a history: ulcers, amputations, vascular procedures. They're already high risk.
Right.
Interestingly, evidence suggests broad population-wide screening to prevent the first-ever ulcer might not be cost-effective, given the overall incidence rate.
So prevention efforts focus more on recurrence.
Mostly, yes. Most research and clinical effort goes into preventing recurrent ulcers in those who've already had one because those reulceration rates are so high.
And what are the key components for preventing these recurrent ulcers?
It truly requires a collaborative, multidisciplinary team, ideally involving specialists like vascular surgeons, podiatrists, diabetes educators, and podorthists, the footwear specialists.
A team approach?
Yes. The cornerstone of secondary prevention is understanding the critical role of those biomechanical factors, limited joint motion, structural deformities in causing ulcers in the first place.
Okay.
The main effective interventions are comprehensive, foot-specific education for the patient and family, regular, systematic foot evaluations in a dedicated foot clinic, and consistent use of appropriately prescribed and fitted therapeutic shoes and custom insoles.
The chapter really underscores how common reulceration is if prevention isn't in place.
It's alarmingly common. Once an ulcer heals, studies show that without consistent prevention, anywhere from 50% to 80% of patients will get another ulcer within the next year.
Half to 80% within a year.
Yeah.
That's, wow. It really highlights the need for proactive, ongoing management.
Urgently, yes.
And the consistent use of proper therapeutic shoes and custom insoles can make a really big difference in reducing that risk.
Absolutely. Numerous randomized clinical studies show a substantial 2- to 4-fold reduction in recurrent ulcer rates for patients consistently wearing properly fitted therapeutic shoes and custom insoles compared to just wearing their own shoes.
2 to 4 times less likely. That's significant.
Very. Table 117.3 in the chapter summarizes several key studies on different footwear types, clearly showing the big differences in ulcer rates between treatment and control groups.
And one final tip on shoes.
Yes, it's strongly advised that patients should absolutely avoid reusing the same shoes they were wearing when their initial ulcer developed.
Why? Contamination, pressure points.
Potentially both. They might harbor contaminants or just contribute to the abnormal pressure that caused the ulcer in the first place. Best to start fresh. Okay, we've covered a tremendous amount today. Let's take a moment to bring it all together with some key conclusions.
It's abundantly clear that diabetic foot complications are far, far from being a minor concern. They have a profound impact on people's lives. It are a huge burden on the healthcare system.
Yes, and as we've discussed, if these complex issues aren't promptly and effectively recognized and managed, they tend to follow a predictable and unfortunately detrimental course, often involving repeated hospitalizations, multiple surgeries, and progressive limb loss.
But the encouraging news, the takeaway, is that this trajectory isn't inevitable. It can be significantly altered.
Exactly.
The chapter emphatically underscores the critical importance of early identification of the at-risk diabetic foot and the active involvement of a specialized, dedicated, multidisciplinary diabetic foot team.
That collaborative, multidisciplinary approach, bringing together all the different expertise, is truly the key to effectively managing these multifaceted problems and ultimately achieving better outcomes for patients.
So to bring us full circle back to where we started, diabetic foot ulcers are definitely not something to be dismissed or underestimated. We've taken a deep dive into that intricate web of factors contributing to them: neuropathy, vascular disease, biomechanics, infection, and the absolutely critical importance of prevention.
And considering this complex interplay, it leaves us with a really important question for you, our listener. Given this multifaceted nature, what are the most significant and impactful changes that individuals living with diabetes can proactively incorporate into their daily lives to safeguard their foot health and prevent this potentially devastating cascade of events?
It's definitely food for thought.
We strongly encourage you to actively explore the resources available, have open discussions with your healthcare professionals, and take those crucial steps to prioritize and protect your foot health.